Alright. So systemic treatment planning, as you all know, we all do this in clinical practice. And uh, when you started your internships, you got introduced to clinical documentation, progress notes, treatment plans, and all of this, right? So why is it important to have a treatment plan? And maybe let's talk about what a treatment plan is. And it's basically a contract between you and the individuals or the family couple that you're seeing. It basically is the number one statement about the nature of your therapeutic process. So your treatment plan is like basically the foundational piece of the work that you're doing um, with either the family, the couple, or the individual. And it also justifies your work, justifies why you're doing the work that you're doing, the interventions that you're applying, and it actually tracks progress. So it's based on multi-dimensional clinical assessment. As you remember when you started internship 1 or internship 2, when you first started seeing clients would do an intake and they would get assessments, right? So treatment plans are based off these type of assessments that we provide to our clients during the initial phase of engagement in therapy. And those assessments then give us the either diagnosis or the symptoms that they're coming with, presenting problems, how the family or the couple or the individual is functioning, and developmental factors. Treatment plans consist of agreed upon goals, the desired outcomes, like why are the family or the couple coming into therapy? What do they want to achieve? Um, the methods that we'll be using to help them reduce symptoms and to help them achieve either first, second, or third order of change. So one important aspect of treatment plans is I think this is something that some beginner therapists forget about. When they're doing treatment plans, they only focus on the bad things or the symptoms that the family or the couple individuals come in with. But we have to focus also on the strengths, like what are the good things that this system or this person has currently in their lives that's been helping them to even be here today. Do they have any additional support? Do they have family members that provide those additional support? Are they engaged with other agencies? So strengths and um, those, I guess, internal and as well external strengths are very important in treatment planning, because then you don't have to, I don't want to say that you don't have to work so hard, but you can use those strengths to like really help your clients achieve their goals. As you all know, you are all in at your sites. I'm pretty sure that your site supervisor or whomever there has told you that signatures are very important when you're creating treatment plans, because that's kind of like the contract of your therapeutic process. And having the signature of your clients also shows that you have gone over this treatment plan with them. Writing goals, that is a very very important part of treatment planning. And I'm not sure like if we have any ideas or anybody would like to share. Um, how do they write their goals? And at your sites, do you have any specific ways that you need to write your goals? And let me just stop share here. So maybe we can go back, and if we can share like what are some of the ways that you write your goals? Like what are the key features of writing goals at your site? or from your own clinical experience? Yes, Faith.
Um, I typically, so at my site, there's like literally no guidelines for anything at all because we use medical software, not therapy software. So my notes are like a lot of like radio buttons that I like pick. So there's like three goals I can pick from. One of them is like alleviate emotional disturbances, encourage personality growth and development, and then the third one is um something equally vague. So when I have get to do whatever I want basically for my own documentation. So I do SMART goals, which are God, I don't know, what is the S? But like measurable, achievable, timely. I try to follow the SMART goal format. I try to make it positive and based on strengths because of the solution focused stuff. So I try to um use a more positive angle. Yeah. It's really weird for them to just have those three things to choose from. It's just bizarre. I don't like it.
Well, I can totally empathize with you because when I used to work at the hospital, we used this medical software that didn't even allow you to write anything in. It was like click, click, click. So you as a clinician feel very limited, and especially if you're practicing from a specific modality. So some of this medical softwares do not have systemic modalities integrated in their blueprint or however they come. Um, but that can be very frustrating. And I'm not sure like if you do have that option to write things in. And yeah,
I
okay.
do, but it's only because for a long time they did not. And then they had to create their own form. So I have to click like a special button that goes into like the special forms that we have. So it's been a thing in the department for a while that we're all kind of frustrated by the notes. But they
Well,
don't want me to write like long notes. But this is more of my supervisor. She wants me to be like quick, vague, like simple, like two sentences, like the most vague overview possible is what she wants. So I try to keep my own more detailed notes elsewhere. It's like a
you're,
whole
yep.
system.
We'll go over that in a minute too. Yeah. Mhm. Maggie.
I think something I feel conflicted about with notes, we're supposed to keep ours pretty vague as well, because most of my clients use Mass Health for insurance, and so they have access to the notes. So I am always trying to keep that in mind. Like, is this person documented? Do they have papers? Like, I do not want to have any trail of that. Just certain details that I don't feel comfortable sharing with a huge corporation. So I'm always trying to balance that.
It is so important. Yes. So you want to be very objective, just straight to the point and very simple. There, I don't know if your software has or you keep your own psychotherapy notes, which are different from progress note. So if you want to, some therapists do their own separate psychotherapy notes, important confidential information they that would jeopardize, like their clients' well-being if these notes were subpoenaed or seen by somebody else. Yeah.
Yeah, and my question with our own personal notes is, I know that there's a lot of HIPAA stuff around that, and like I can't necessarily meet those, like having them behind like two locks, or so I also feel strange about having that information on me. And we are working with a lot of high needs DCF involved people, so there are chances of things getting subpoenaed, and that's a real fear.
Yeah. Mm. I always refer to objectivity, just be objective, um, simple, what you've seen in the room, what you've done in the room with the client. Um, and I've gotten my notes subpoenaed in the past, and once like you just stating the facts, like if you just state the facts of what you do and how you did it, most likely you're fine. But I I hear it. I'm curious if uh, anyone else has experienced that or has gotten subpoenaed already.
So just for clarification, if our notes are subpoenaed, does that mean like the legal system would have access to our personal notes? Because like I don't even put clients' names on that.
No, so your
Okay.
your therapist notes are your notes. It's basically kind of like a journal for you.
Yeah. Okay.
Um, so they won't subpoena that. What they would subpoena is what's in the system, as far as progress notes, treatment plan, assessments, and all that stuff.
Okay.
Yep. Yep. So it is complicated, and this is why I always tell students bring it into supervision. Also consult with your supervisor, site supervisor, with the clinical director, because they have more experience, right? And it can be a very scary and anxiety provoking situation as a student, as a beginner therapist, to get all of your documents, subpoenaed. But just know that if that ever happens during this transition, you can bring it here. You can bring it to your site supervisor, because most likely they would have most of the experience at your site in the process in how they do things when documents get subpoenaed. But it is, I just want to validate that it is a very anxiety provoking and stressful situation. Yeah. So going back to writing goals, like you said, Faith, some people use the SMART goals, right? Um, and why are goals important in treatment? And they're most important because they provide a final destination. They provide not only the client, but you as a clinician, this visual of this is what the client wants, and this is where we're headed. So we have long-term goals, which is the final destination. Then we have short-term goals, which is basically the route or the path that will get us to those final destinations. And how we get to, I guess, creating these goals is by defining the problem. And that's when, your clinical hypothesis comes into play, and you reassessing that clinical hypothesis with your clients and really restating that, being clear about this is the problem. Do you agree? Can we create a contract around this? And then that's when the goal treatment process kind of like should start. So goals should be created very specific and concrete, measurable. Some agencies are really hard on this, like they specifically want your goals to be measurable. Um, in our practice, they should be systemic. If you're working with in a relational case with a couple or a family, some agencies require them to be behavioral too. Um, but this is not, all of this does not apply like check to, private practice. You can have measurable goals that are systemic, uh, specific, and that show the composition of the family within, that um, the system and the problems that are embedded in that composition or that systemic dynamic. So I always encourage students to refer to what your site requires. This is a little different when you're in private practice. Here we have an example of a measured goal. Client will demonstrate better anger management skills as evidenced by decrease of outbursts at home and work, elimination of violence and other forms of physical aggression, decrease of incidents and disciplinary action by employer. So that as evidenced by provides basically what's gonna happen in your session. What are the things that the client will do that will show that they have achieved some sort of progress. And some of you are already using this at your sites. Here's another example. Client couple will demonstrate increased intimacy as evidenced by higher scores on this assessment or the other assessment, couple satisfaction scale. So there's another way to measure your progress. Decreased conflict and contempt, increased sexual activity. So all this are multiple ways of you measuring your progress. I'm in private practice. I still use as evidenced by because it provides me a clear vision of where the client is at, and then I can state that to the client. Well, for example, I would say, hey, we did this BHQ9 last month, and this is where you at this month. So it shows that you've achieved some progress or something that you're doing, and then we just talk about that. What have you done during the last month that your PHQ-9 scores client decrease so much? That gives the client a visual of like, okay, I'm doing something here and therapy's working and I'm putting a lot of work into this. For more assistance about treatment goals and how to write them, if you want, you can check these 2 articles. I really encourage students to get the second one, the Gayheart and Total. This is something that I use in foundational theories class, and I still use as a licensed clinician. So Gayheart and Total 2003. It's a really good book to use when creating treatment plans, systemic treatment plans that are focused on your particular modalities. So we use treatment plans as anchors. You know, they serve as a clinical justification for the system, the approaches that we're using, the modalities, the interventions, the recommendations that we give to people, and the referrals that we provide. So your treatment plan holds all of this. That's why this is such an important document. So what happens over the course of treatment should always be linked to the agreed upon treatment. And this is why your progress notes should reflect what's on your treatment plan. So it's kind of like this threading of a needle. So what you have on your progress note and the interventions that you've applied in sessions that you write in your progress note should reflect the treatment goals, objectives that you have written in your treatment plan. Whatever the size, whatever happens, like if you change anything in therapy, you have to ask this question, right? How does this serve the agreed upon treatment plan? Is you making the decision with the client, we don't need to have weekly sessions anymore. Is that benefiting some of the treatment goals that are written in the treatment plan? And if that's the case, then how do we document that? What are the measures that you have provided that show that the client shouldn't or doesn't need to come see you as often as they were? So you can support this by measurements, assessments, and then you would have to go into the treatment plan and maybe check that goal. Client has completed X amount of sessions, or this goal reduced depression because of their PHQ-9 has decreased 5 to 10 points this month. Therefore, we're making the decision to not decrease the frequency of therapy. When you modify the treatment plan, anything that is modified, and again, this also applies in private practice. And I'm emphasizing that because people sometimes think that private practice, a lot of this does not apply to private practice, and it does if you want to be an ethical clinician. You if you take insurance, this applies all the time. But if you don't take insurance and you are just self-paid, like out of pocket, in private practice, I always refer back to, is this ethical? Is not having a treatment plan with goals, objectives, and measuring progress, is that an ethical thing? So just ask yourself that question. I know all of you are at sites, but it is important to go back to your ethics, professional ethics, right? Reviewing treatment plans, the gold rule is 90 days, every 90 days, or some people do it every 60 days, but you can like decide, or whatever your site has and you have agreed upon. So this varies. In private practice, I do it every 90 days, and clients find it very helpful that way. So again, whatever you decide to do in therapy should start with the question, how does this serve the agreed upon plans? Whether you're changing something individually or or in relational psychotherapy with a couple or a family, how is this serving the agreed upon treatment plans? This is more of the same. Termination should occur when the goals of treatment have been achieved. Again, this varies. Sometimes there's early termination because of X, Y, and Z and other things that, get in the way. But you decide with your client, and depending on your approach, you can like make the decision with your client. That's a little bit about, let me just stop. An IFS progress note. In This is how I write my progress notes. I'm not saying that you have to write them the same way. I just want to highlight some important pieces of a progress note here, okay? And you might be writing progress notes at your sites very differently than how I write my progress notes right now. But just thinking ahead, when you become a fully licensed clinician and you're in private practice, what are the things that need to be in my documentation to keep me not only protected, but to keep my license protective, right? So these are things that, regardless if you take insurance or you are a out-of-pocket, self-paid clinician in private practice, you will need to have in your progress note. You will need to show to the court if you ever get subpoenaed. Most importantly, we already know clients' information, your information, diagnoses are very important to have on a progress note. The type of service you're providing, it's also important. If you're billing insurances, they will ask you for a code, a specific code. So in this case, this client is coming with insurance. So here's the code for individual sessions. And we go into the progress note. I like to keep things simple. I like to state the main problem, okay? And again, if you have a software that you can go back to your previous note, this is super simple. So you don't have to write all of this all the time, which I'm pretty sure some of you are already doing that. So the main complaint, what they came in for like the first initial intake, this was the problem. The client stated, he's been having PTSD, depression, anxiety, nightmares due to child abuse and neglect. That was the primary complaint. Then in the intake, I just, as I was assessing and using IFS right from intake, I, wrote down these protected parts. So we have managers, firefighters, and exiles. Then the second piece here is what I update at each session with the client. So these are kind of like current problems that happened since the last time I saw the client. So we've been working on, an affair that he had 6 months ago. So he's been thinking more about that, that's exactly what he said. I've been processing the affair. And I use client's quotation in progress notes as well. When is appropriate? If the client, this is, what we were discussing earlier about progress notes, what should go in your progress note and what should go in your psychotherapy notes or your private notes. So this is very simple. The client has been processing the affair. The other session here is I'll remind it for myself. I take the goals that we've agreed that are in the treatment plan and I put them in the progress note. So I created this section of treatment plan goals and I just put them there to just give myself a reminder before I see the client, what are the goals that we've been working on? It makes it simple. So I don't have to go back to the whole entire treatment plan and look at that and review that again. Then I keep track of, the progress, the progress that client has made. So we start off with a check-in and the client, reported to me that he's been using more curiosity to engage with his wife. He's been using more curiosity internally to engage with his wife and getting to know the factors that led to his affair. Very simple, one sentence. That's tracking progress right there. We always want to assess for risk factors, substance use, medications. This right here, observation, is in session, what you observe, how the client is coming in. Okay, so it is important to have that at each touch point with the client, because then you can refer back and say, well, 2 weeks ago, you came in with a very sad, depressive mood, and your affect was X. So now we're seeing an improvement. You're coming more happy, more normal, stable, and with an appropriate affect. Content or topics that we discuss, this is not necessary. It can be helpful to just give you a little reminders. This is just one line. This is the topic that we focus on in this session. Then the two most, I would say, second most important pieces of your progress note are the therapeutic modality and interventions section and how the client responded to those interventions that you provided in session. So in this case, as I mentioned before, I've been using IFS with this client. And very simple, I state my interventions. I encourage client to speak for rather than from his part. Use this session to process parts that are questioning the affair and wanting to look back at childhood history. That's it. Object, straight to the point, simple. Anybody can understand that, right? So, and then how the client responded to this. Again, you want to be objective, simple, straight to the point. He was receptive to those interventions and the feedback that I provided. He used the session to continue processing the questions that were coming up for him now that he had been paying more attention to his internal experiences related to the affair. The client made a list of factors that contributed to the affair. Here's a list. And we restated the protected parts. So that's how he responded. He was able to talk about his pride, his performer, high achiever, the depression, the grief. We touched on that little 9-year-old, the 12-year-old. So it was more of a curiosity, exploratory intervention from an IFS perspective. Just restating that, yes, I do have all of these protective parts. And yes, I recognize now that they are coming from these wounded childhood experiences. For my next session, this is very useful for me. What's the plan? What's my plan for my next session? So we're thinking about doing some parts mapping and establishing a contract with the targeted parts. And then what is he gonna do? Client will use curiosity to engage with his protected parts. And the recommendation stays the same. Thoughts, questions about that progress note?
Can you send it to us?
Yeah, yeah. I redacted all personal information, so I will. Yep. Yeah.
Very organized. I'm like Starr's brain. Starr's brain's so organized. And I know like experience and stuff too, but yeah, I just appreciate how you laid it out. I find myself getting tripped up by needing to do different structures because I have 2 sites. So I'm like what you have is like the happy medium between them, and I'm like, can I just do that? But like not yet. So
Eventually. Eventually. Yeah. And one last recommendation, look at the interventions from your models. Get familiar with those interventions. And you don't have to make them so complicated when you're writing your documentation. You saw how I just put curiosity. That's an intervention right there. We're using curiosity in session to promote self-led connection with parts. So you can use very simple language in your documentation. Yeah. Mindful of the time, we only have 5 minutes, and the last thing that I was gonna go over is the safety plan, which is here, and I'm also gonna send a copy of this. So I think we talked about safety planning in one of our supervisions like last month, but it is important to know what a safety plan is, how to create one, especially when you have clients who have history of suicidal ideations, passive or current suicidal ideations, self-harming as well. But the rule of safety planning is basically creating a contract with your client that now the client can follow these steps and know what to do when they're experiencing, these overwhelming feelings of wanting to hurt themselves, wanting to hurt others, or even when they have a plan to commit suicide. So I just want to be clear that if a client tells you that they have a plan and they've had a history of suicidal ideations, you don't need to create a safety plan in that case. You need to call 911 and refer this client for a crisis evaluation. If a client tells you, I have a plan and I know how I'm going to do this, you should stay with that client and call 911 and just talk with the client what's going to happen next. Safety planning is kind of like this pre plan that you create with your client when they're experiencing passive ideations without plans. Okay, so I just want to make the difference here. So the first thing you want to ask the client is about warning signs. What gets them there? How do I know they're about to harm themselves or harm somebody else? Then you guide them into talking about the internal coping strategies. What has helped in the past? Tell me about anything that you can use when you're feeling like so overwhelmed that you get these thoughts that you don't want to be here anymore. You don't want to live anymore. What's helpful? What has helped? Then we go into more of a who's there for you, who can be there for you, who can you reach out? Okay, if these internal coping strategies do not work, who can we resource to? So you want to make this very clear, name and phone number. Again, when clients find themselves in these situations of a very strong suicidal ideation that's taking so much space within themselves and in their heads, they spiral. Okay. So it's really hard for some clients to even go on their phone and find phone numbers and try to call people. So having this handy is it's really helpful. People who they can ask for help immediately, somebody who they can call, or like that will be there for them and that can provide some sort of help. And professional agencies, I always include myself. um, you can include the PCP or any other professionals that might provide some help to them during this crisis. Again, this might be silly, but yes, finding the nearest hospital, just like writing that down for the client with the client and the phone number, super important as well, because again, they're in this spiral space. I always tell my clients, these are the numbers. If you get into that space at 2 a.m, might not be available to be there for you, but these people at the Suicidal Prevention Lifeline will be available. And you can text or call them, or even go online and chat with somebody else. Making the environment safe. This means like what needs to be removed from the environment in order to make it more safe. So if there are guns or any other harming tools that the client had used in the past or think about using, it is important to talk about these and let other people know that, these are my thoughts and this is what I've been thinking about using. Safety plans should be shared with somebody who the client feels connected, safe with, okay? If they live with somebody, they can share it with that person. But sometimes, clients don't have anybody. Who are they going to share their safety plan with? That's a great area where, you can talk with your client and see if they would, like find somebody or even feel grounded in using this plan step by step in contacting the people that they have um, added to their safety plan. So it's more of a preventative thing rather than thinking about safety plan as if the client has a plan and is currently suicidal. Safety plan doesn't work in that space. Yeah.
What you were saying before, that if the client has a plan, call 911. Could that also be like, I know around here, clinical and support options has like a crisis line.
Mm-hmm.
Could that replace 911?
So crisis lines are just like when people are in crisis. So if this is happening at 2 a.m, I will load my client with all of these resources. If this is happening, you're not able to use your treatment plan, I want you to call the crisis line and be on the phone with them. They will guide the client to, get immediate assistance, to go to the emergency room, or even send an ambulance to their home. Yes, Simone.
Just to Maggie's question, because we work out of the same building but different organizations, our new clinical director used to be the director at CSO. And what she let us know is that if you send a client to CSO, or if you call CSO and say, I have someone who really needs support right now, they can sometimes like send someone over to get the person, or like, this is for experienced clinicians, not for us, but like walking the client over to CSO because it's not that far, but that CSO will prioritize people who like come in and need support. But I don't think it's a replacement for like for anything. There's just like a vacuum, as we know, like for getting mental health support that's not the police. But
Yeah.
yeah.
If the client is in session with you and sharing with you that they thought about this plan last night and they do have a plan, and when they go home, this is what they're thinking about, that's your call right there. Okay. So you immediately have to call an ambulance. You talk through it with the client. This is a lot of clients have big fears about going to hospitals, getting hospitalized, and there's a lot of anxieties around this. So the client might not really see the benefit of doing that. Bye, Simone.
Bye. Thank you.
Happy holiday. So yeah.